It is my great honor and privilege to introduce today's speaker, Dr. Ricardo Lloyd. He currently is the professor of pathology and laboratory medicine and directs a translational research laboratory in University of Wisconsin-Madison. He actually got his MD and finished his residency training there. And then he pursued a surgical pathology fellowship in Memorial Sloan Kettering Cancer Center in New York City. And he held several faculty positions in several prominent institutions, including University of Michigan and the Mayo Clinic. He has made a great contribution to our pathology societies. He is the president of Endocrine Pathology Society in 2000 and the president of USCAP in 2004 and 2005. He's currently the editor-chief of Human Pathology and serves as an editorial member in many journals. He's a very productive physician-scientist, has published several hundred papers. And his basic research is in cancer stem cell and epithelial mesenchymal transformation. And his translational research really set up standards and change our way practice in anatomic pathology. And he's one of few anatomic pathologists that really has expertise in molecular diagnostic. He directed an in situ hybridization laboratory and a molecular diagnostic laboratory in Mayo Clinic. And today he's going to tell you how thyroid pathology being evolved over the years based on his research and also the clinical evidence and data gathered from other investigators in the field. So let us welcome Dr. Lloyd back to Minnesota.
Yeah, thanks very much for the kind introduction. I'm really happy to be here. I've met several of my colleagues and former colleagues and even a mentor, Dr. Powell, who's been an inspiration over many years of my career. So today I'll be talking about thyroid tumors. The first part would be a lot of histopathology. Then the last 10 minutes or so, we'll talk a little bit about the research that we're doing with epithelial mesenchymal transformation as it pertains to the thyroid. As you know, thyroid cancer is the most common thyroid cancer, or the papillary cancers, so at least 80% or so of tumors that we see. And most of these are very low grade, relatively indolent tumors that once they're taken out by surgery, not much additional therapy is needed. Follicular cancer used to be a lot more prominent, but now it's only about 5 to 10%. And then different type of cancer in the thyroid, or the medullary thyroid, or the neuroendocrine tumors, again a small percentage. And then the poorly differentiated, recently described group. And then of course, historically, anaplastic has been the worst type of thyroid cancer that we've had for many, many decades, and still remains a very aggressive tumor. So in the first part of my talk, in going through the differential diagnoses and so forth, I'll refer to the WHO classification, which has not been published officially as yet, but will be out within the next 2 months or so. And this will be updating a lot of the concepts about thyroid cancers. As those of you who are working partly in the field of cancer, thyroid pathology know, one has a follicular cell, and then this usually has a series of mutations and goes on to form the papillary thyroid cancer. The common mutations would be like BRAF or BRAF as such, and then these de-differentiate or can de-differentiate towards anaplastic thyroid cancer, the worst type of thyroid cancer that we have. Then another line of mutations would be the follicular thyroid cancer, that small percentage in which one has translocations such as PAX8 PPR gamma, and these again can de-differentiate towards anaplastic. And even follicular adenomas, the benign tumors, nodules that have not invaded, usually would have some mutations such as the RAS family of mutation. So one sees mutations not only in the benign, in the malignant lesions, but also in the benign lesions in the thyroid. And this has been known for more than 15 years or so. More recent information about genetic mutations in the thyroid has come from the TCGA project sponsored by the NIH, in which they looked at 496 cases of papillary thyroid cancer and uncovered a lot of new mutations that were not appreciated before with such a large group. And this has led to this subdivision of papillary thyroid cancer, that major group, into two groups. The groups that have BRAF type mutations, and these are certainly fairly common, and then another subgroup that has RAS-like mutations. And these would include historically the follicular variant of papillary thyroid carcinoma. And we'll talk about that a little later on with the NIFP, a new concept, and other things like these. So these are the two groups and the additional mutations that have been discovered in these tumors. Another important mutation that was just described 3 or 4 years ago in thyroid that helps to prognosticate if a tumor is going to be aggressive or not. As we said, most papillary thyroid carcinomas are low-grade, indolent tumors that can be taken out by surgery and the patient is cured. However, there is a subgroup, say 10% or so of these tumors that are more aggressive, and it's, in addition to BRAF, telomerase promoter mutations are common in the more aggressive papillary thyroid carcinomas. Overall, only 11-12% of these would be present in the conventional papillary. But if you look at the more aggressive subtypes, the ones we'll be talking about with the histology, you'll see that these numbers are even 40-50% of those subtypes that would have telomerase. Hence, telomerase promoter mutations would be a good prognosticator of how aggressive a tumor will be. And then their small percentage, the poorly differentiated at 1-2%, has a fair number, as do anaplastic thyroid carcinomas, the really aggressive form of these cancers. So the orphan antinucleus is one of the features that one uses in diagnosing thyroid tumors. And thyroid tumors are relatively easy to diagnose in terms of the conventional type. First-year residents, second-year residents can usually recognize these. And it's usually the more aggressive tumors, the variants that we'll discuss briefly as we go through, that are more difficult and more controversial in diagnosing. And with those, it's important to diagnose those because they prognosticate a more aggressive behavior for those tumors. But the overlapping nuclei, the nuclear grooves, the cleared out nuclei are some of the features that we all recognize in papillary thyroid carcinomas. Microcarcinomas are little tiny tumors less than a centimeter in size, 1 centimeter or less in size. And these are sort of, in looking at the two subtypes of these, they sort of herald or predict how some of the bigger tumors will behave. So these are tiny tumors, sometimes incidentally seen, like many prostate cancers at autopsy. They're often called pathologist cancers because they don't really affect the behavior or outcome of a patient. It's usually an incidental finding, either at autopsy or at surgery for another lesion. They only recur or metastasize in a small percentage of cases, 5 to 10%, and rarely are they associated with the demise of the patient. And when they've looked at the ones that recur, they do have more BRAF mutations more commonly, or they're at the edge of the thyroid capsule, and so they can recur because of that incomplete excision. So there are two basic types of these. Tumors that are circumscribed or non-invasive, as one sees here. And so these are, again, the ideal pathologist cancer in quotes, or incidental cancers, that if you see 100 cases of autopsy thyroids, probably, depending on the country you're in, 10 to 20, or sometimes in Japan, even a slightly higher percentage, 25% of patients may have these little tiny incidental cancers. And once they're taken out, nothing else is really needed in terms of treatment. On the other side, we have the invasive or infiltrative papillary carcinoma. This looks big because I'm just showing a high power to show that we have the edge of the thyroid here. And so these are infiltrating nests of cells. Morphologically, they're very similar. So it's really only the fact of invasion or infiltration that makes that difference between these two types. And this would be the subtype that's more likely to recur in terms of microcarcinomas. Some people believe that microcarcinomas should not even be called carcinomas as such because they're so indolent, low-grade lesions and usually don't require additional treatment. When the pathologist is looking at thyroid cancers, and we get cases sent in consultation not uncommonly, there are things that should be distinguished from the cancers. And papillary hyperplasia, one can do that by morphology, looking at the cells, looking at the nuclear features, or you can use molecular testing, looking for certain types of mutations, absence of, say, BRAF mutations or telomerase promoter would be helpful. But morphology is usually sufficient to recognize papillary hyperplasia. And this is emphasized in the new WHO book. If you're not used to looking at a lot of thyroids, you can see some overlap. There may be enlargement of the nuclei, and it appears as if they're overlapping. But the other features, such as nuclear grooves, invagination into the nuclei, into the nucleus, would not be the features that one would see in the typical papillary hyperplasia. So you can be pretty comfortable these are benign and will not recur or metastasize. Other things that may be confused would be the so-called solid cell nests, in which one has cells that have some of the nuclear features of papillary thyroid carcinoma. So it becomes confusing. We get cases like these sent in consultation a few times a year, where you have grooves, irregular nuclei, and so forth. But these are known to be just remnants from the ultimobranchial bodies that migrate into the thyroid. But histologically, they can be a problem for the pathologist, especially if you're not used to seeing a lot of thyroid tumors. Another lesion that's a real tumor, but still essentially benign, described by Dr. Carney down the road at Mayo Clinic many years ago, is something called hyalinizing trabecular tumor. And if one is a cytopathologist, this is really a very vexing problem because they have a lot of features of papillary carcinoma. They have the nuclear holes, they have grooves present in some of the cells, and so the cytopathologist is often has difficulties in sorting this out from the typical papillary carcinoma. So they come up with a false positive diagnosis from time to time. So when the patient goes to surgery, and these are usually seen as benign lesions, on histology they can be readily recognized, but they still have the features, the holes and the grooves, some of the features that we see with papillary thyroid carcinomas. Again, they would not have most of the mutations that you see in papillary carcinoma. So if you had to go to that next step, that would be one way of separating those. Dr. Carney and his collaborators, again, probably a decade and a half ago, realized that the Ki-67 marker that's used so extensively for proliferative activity stains the cell membrane of the hyalinizing trabecular tumor, relatively unique. So this became a useful marker if one had difficulties at the H&E level in separating these, membrane staining, since conventional papillary thyroid carcinoma would not have this membranous pattern of staining in these tumors. So that's also in the differential diagnosis. So that's one end, indolent lesions, some of which may look like papillary cancers. The other extreme are the tumors that would have this high telomerase promoter mutation, such as a tall cell, columnar cell, solid variant, diffuse sclerosing, and then a tumor that we described in my last couple of years at the Mayo Clinic, the hobnail variant of papillary thyroid carcinomas, all of which sort of confuses the typical reader who doesn't see thyroid a lot in thinking that all thyroid cancers are indolent. And the exception would be these, in which at 10-15% of cases one has recurrence, and the cases of hobnail and tall cell even demise from some of these tumors. So how does a pathologist recognize the tall cell variant? Cells are 2 to 3 times as tall as their wide, prominent nuclear pseudo-inclusions, usually very elongated follicles. And Dr. Hazard at the Cleveland Clinic in the 1970s described a series of 12 cases of usually males that were older and had larger tumors. So morphologically, this is what we recognize here in terms of these tumors. Nuclei are basally located. They have a lot of cytoplasm, and this gives that tall cell appearance to the cells. But in addition to that, they have these elongated follicles and then a few other features that would help in the diagnosis. Here's a higher view showing the type of inclusion one sees. This is just the cytoplasm projecting into the nucleus of the cell. The TCGA project from the NIH studied a large series, about 75 of the 496 cases were tall cell, and they found that the mutation rate, or a lot of the mutations, were identified in this subgroup. So again, more aggressive tumor, more likely to have more mutations than the more indolent or conventional papillary thyroid carcinomas. We did a study way back when I was at University of Michigan. Terry Johnson was a resident at the time, and these are relatively uncommon tumors. So we were able to get cases of tall cell, 12 cases, compare these to the usual or conventional papillary thyroid carcinoma. And so with this case control study, you can see that these tumors are indeed, even back then, more aggressive. Extrathyroidal extension, metastases, even some patients died of their disease. So with this small series, we sort of confirm what Dr. Hazard had reported a few years earlier. And now most clinicians, most endocrinologists are quite familiar with the tall cell variant. So when we present cases at tumor board, endocrine tumor board, and the tumor is behaving aggressively, they're always asking, is this a tall cell variant? And certainly this is one of the more common aggressive, about 5% of total thyroid cancers, but isn't the only aggressive variant that we have, and which pathologists should be familiar with. For example, a less common type is the columnar cell variant. Looks a lot, but in metastatic foci, this can look like other types of cancer. So again, it can be confusing with these tumors, and one can use immunostaining to help sort out the differential. So here's a tumor. Those of you who study prostate pathology or GYN pathology, this could look like an endometrial cancer or prostate cancer of some type, but this happens to be a columnar cell variant, and it is present in this case in the thyroid. But if it's a metastasis, one can do immunostains such as TTF1 that is relatively specific to tumors of the lung and the thyroid and help to sort out in that differential diagnosis. These haven't been studied extensively for a lot of other mutations, but certainly BRAF is present in this subgroup as well. And then another type, which is even more important in terms of parental worries, is that this occurs usually in younger patients, 10 to 30 years of age, the so-called diffuse sclerosing type of variant. That's aggressive tumor present in the lung, lots of lymph node involvement at the time of surgery. But because one of the reasons, probably because they're younger patients, they rarely die of disease, even with metastatic tumors in the lung. And the histology would be like this, that one should recognize with the H&E, in which one has cells that look sort of squamoid. Those of you who are surgical pathologists would recognize the squamoid. Lots of lymphocytes in the background. And then you'd wonder about an immunologic relationship between that tumor with the microenvironment. And then higher power, one has calcification, pneumoma bodies. That's typical of some thyroid cancers, but in 100% of this diffuse sclerosing variant. And if you recognize that in a child, then they usually, again, would titrate the dose of radioactive iodine, the additional treatment that one does with thyroid papillary cancer. Another type that's still under-recognized today in 2017 is the so-called solid variant of papillary thyroid carcinoma. These are often lumped with the follicular variant, but as you can see, there are very few follicles, if any, within these tumors. So the solid growth is one of the things that really that's associated with the more aggressive growth. The cytologic features of papillary cancer are present here, as we have outlined before. And then the final lesion in this group that we'll mention today is the so-called hobnail variant of papillary thyroid carcinoma. When I was at the Mayo Clinic, we received a case of this hobnail variant of the tumor, and this is actually that index case, in which we had follicular variant pattern in many of these areas. But there are these peculiar cells. You can see how different these look from the adjacent areas. Remind you of hobnail that one sees on boots, such here and here. Big nuclei, prominent nucleoli, and fair number of mitotic activity in these cells. We did all the workup of these cases, showed that they were expressing thyroglobulin, HBME1, a marker of thyroid tumors, papillary tumors, and concluded that that was the case. Then these are some of the variants that one sees with this hobnail variant of tumor, even micropapillary pattern. They also express TTF1, a thyroid transcription factor, and P53 immunostaining, but we have a paper in press with our collaborators in Italy showing that in Oncotarget that this is indeed a mutation of P53, which is pretty rare in papillary thyroid carcinomas in general. Anaplastic tumors commonly have P53 mutations, but usually not papillary. So the first series that was published, you can see several of these patients died of thyroid cancer. And some were middle-aged patients, even one younger patient that did better than the others. So with this index case, we made the diagnosis. About 6 months later, the pathologist that sent us the case sent another slide. So, are you sure this was a papillary carcinoma? We had multiple lesions. Patient had multiple metastases in the liver at the time. And papillary carcinoma usually do not go to the liver. And again, we did all the workup, and we were pretty convinced that we had something unique. But it was only one case, so we waited a few years, and other cases came along. And then Dr. Ascioli, who was a really outstanding histopathologist from Italy, came and spent 1.5 years with us at Mayo. And she went through the files at Mayo, and you know the files at Mayo go way, way back in terms of the histologic slides. And so we were able to come up with these initial 8 cases of this lesion. And then in the literature today, this was 2010, in the literature today there are these 70 cases of this hobnail features, and this is one of the new additions to the WHO that will be out in the next month or two of this really aggressive variant, which we just call moderately differentiated. It has multiple mutations, but it still expresses thyroglobulin and TTF1, which one does not see in anaplastic cancer. So even though it's an aggressive tumor, it's not morphologically or biochemically like an anaplastic thyroid carcinoma. And then we have another new addition in terms of the WHO. And this is the evolving concept of the follicular variant of papillary thyroid carcinoma. Here is a thyroid, and from the back of the room, or even maybe the front of the room, you really don't see much of a difference between this area and that area, except that it's separated by a capsule. And when one looks at this area under high power, one sees that the cells have the cytologic features of papillary thyroid carcinoma. And way, way back, Dr. Lindsay at the University of California had written a monograph about this follicular variant, tumors that had cytologic features of papillary carcinoma, but behaved more like papillary cancers in the late 1960s. And then Dr. Rosai, when he was at this institution, described 6 cases of these that made the tumor, sort of established the tumor as a really relatively aggressive, another variant of thyroid papillary carcinoma by its metastasis to lymph node and other features. And this has evolved. One of the features that one can use immunohistochemically to recognize this papillary carcinomas and some follicular carcinomas is a stain with HBME1, which is Dr. Hector Batifora, who is a pathologist at Northwestern and then moved out to City of Hope. And he developed antibodies and was looking at mesotheliomas, but then serendipitously serendipitously found that papillary carcinomas also express this on the membrane. We still don't know the target of HBME1, as the monoclonal antibody has been available for some time. And this helps to separate papillary tumors from other types of tumors within the thyroid. So one pathologist went ahead and made diagnosis of follicular variant, and some of the cytologic features of follicular variant can be very subtle. So a lot of things were called follicular variant of papillary carcinoma. The people have noticed over the last couple decades that the incidence of thyroid cancers have been going up and up. And a lot of editorials have been written about this in New England Journal and other places. One of the reasons, of course, is that this follicular variant was probably overdiagnosed and has been overdiagnosed. Another one is that people were calling microcarcinomas, those tiny ones, as carcinomas as such. So these have contributed. But there are probably other factors that we haven't sorted out to explain this still continued increasing incidence of thyroid papillary carcinomas. So some astute observers before noted that if these lesions were circumscribed and non-invasive, that they behave fairly indolently, unlike the tumors that were invasive, just like the microcarcinoma that I showed you earlier. And the cytologic features are seen here. So a series of pathologists went through more than 200 cases of these non-invasive tumors and tumors that had the same cytologic features that were invasive. We met in Boston a couple years ago during the USCAP meeting and went over the cases in person after about 8 or so teleconferences and settled on this name, very awkward, non-invasive follicular thyroid neoplasm with papillary-like features, more easily called NIFP, and that's easier to remember. Everyone's caught on to NIFP. And so NIFP has really become a useful diagnosis. Why is that? One, most of the non-invasive tumors are thought to be indolent tumors, not necessarily benign, but almost as indolent as follicular adenomas. So if a surgeon takes out a lobe of the thyroid gland, one has a diagnosis of NIFP. One doesn't have to go and take out the other lobe, so a second surgery isn't needed. So one doesn't have to, that expenditure of funds for that. One doesn't need additional therapy such as radioactive iodine and other things that are used to treat the conventional, even some conventional papillary thyroid carcinomas. So it's made a very big difference in the behavior of endocrinologists and surgeons, endocrine surgeons with this diagnosis. Here's another example of a NIFP. This was in the original article in JAMA Oncology. Circumscribed lesion. So looking at this grossly, you can't really tell if this is a follicular adenoma or some other tumor. It looks rather solid, very rigid, so one would suspect that it could be, that it is a neoplasm rather than an adenomatous nodule. Under the microscope, we do not see evidence of invasion of a thin capsule. And these may not even have much of a capsule, maybe 1 or 2 fibroblast layers, but just circumscribed and non-invasive to make the diagnosis of NIFP. Here's the other end, where one has the cytologic features of papillary, but they're invading blood vessels, as one sees here. So this is a frank cancer, low-grade cancer, but a frank cancer as such. And so there are strict criteria that were set forth in terms of not designated microcarcinomas as NIFP lesions. They're still indolent on their own. If you had multiple lesions in the thyroid, one really multiple of these lesions, one did not use that diagnosis. And there are some other features that one should adhere to before making the diagnosis, such as having a solid variant pattern that was often called follicular variant in the past. So with this lesion invasion, one can tell the surgeon at the time of frozen section that you're indeed dealing with a real cancer and not a NIFP lesion. How do these lesions evolve? Papillary, as we say, have BRAF as the main conventional papillary, and one sees these in most of the thyroid lesions. The NIFP lesion belongs to the follicular pattern, and these have RAS mutations, as do follicular carcinomas, and these, of course, presumably evolve that way. But some NIFP can go on to become invasive tumors by subsequent mutations, is the thinking. This hasn't been shown in any definitive study as yet, but that's the hypothesis that should generate more information within a few years. So we've sort of come a long way in looking at papillary thyroid cancers and thyroid cancers in general, as will be summarized in the WHO. We used to have 3 or 4 subtypes, and like in most areas of surgical pathology, we have all of these subtypes, some of these we haven't really talked about before in terms of time, but they're all here, and some are more aggressive, some have more mutations, which is usually associated with the more aggressive tumors than the conventional, in addition to the conventional papillary thyroid carcinoma. Follicular carcinomas, in terms of the new WHO, just to say a few words, in the general textbooks, there are tumors that have invaded into blood vessels or through the capsule, and those are considered as tumors. Now the tumors that are just within the capsule and form a little mushroom or upside down mushroom, we still consider these as aggressive lesions, and you should find vascular invasion to really be sure, as one would see here in this typical vessel with the tumor cells adherent to the vessel wall. Hurtle cell used to be another variant of follicular carcinoma. In the upcoming WHO, these will be in a category by themselves because some of the molecular changes are different from regular follicular carcinomas. And of course, one would use the same historical criteria. One has a capsule, and there's no hint of invasion into the capsule in terms of a Hurtle cell or oncocytic adenoma, in contrast to the oncocytic carcinoma, where one has invasion into capsule and even in vessels, as one sees here. So one of the changes in this new WHO will be that one has minimally invasive that was there before, but it's a little broader now in terms of the number of vessels. Angioinvasive, the most common type of follicular carcinoma. And then the rare tumor that's widely invasive that the surgeon can recognize when he or she is operating on the patient. The blood vessels in the neck close to the thyroid are bulging with tumor cells, and these are the very aggressive thyroid tumors of this subtype. Then there's a group that Dr. Rosai had a meeting in Turin some years ago and developed criteria for these poorly differentiated carcinomas, which are sort of in between papillary, follicular, and anaplastic. And so these are the criteria that one uses to diagnose these. And the striking thing about these tumors in general, in addition, is that the nuclei are relatively uniform. So they remind one of the islets of Langerhans in part. So the islet cell or insular is one type of this. And so one has these nests. But notice the uniformity of the nuclei of these cells, and they're round, which takes them out of the papillary type group. Dr. Azioli, when she visited our lab in 2009 and 2010, again went through the files at the Mayo and asked the question, how common are these in the U.S.? Since they're mostly reported, say, in northern Italy and the mountainous areas of Italy, and we found, using those criteria, that even though there are 6.7% of the cases in Italy, only a small percentage of cases, at least in Rochester, Minnesota area, and patients who went to the Mayo Clinic had these tumors. So they're a lot more common in some other parts of the world than, say, in this one place in the USA. So in summarizing this part of the talk, we have many new variants of papillary thyroid carcinoma. Some of these are aggressive. We know a lot about the molecular makeup of many of these tumors. This minimally invasive follicular invasive variant of carcinoma is more frequently diagnosed, and it's really very helpful for the patient in that the patient does not need another surgery, patient does not need additional therapies if this diagnosis of NIFP is made here in the third point. Any questions or comments? Yes, Doctor.
What do you bring in molecular? Just not in research, but just
in clinically. Yeah, it's been adopted more and more. And there are two different approaches that have been taken in the literature, say, in the last 10 years. One is looking at tumors. One does the cytology. There are cells there. You can't tell if it's benign or malignant. Some of the cytopathologists would call it FLUS. And then they would do a screening of several markers. That Vericyte company that was in California published in New England Journal about 4 or 5 years ago. And so molecular is used to support a benign lesion. And so that's one approach. The other approach, Dr. Nikiforov at University of Pittsburgh now, has developed a series of markers, including BRAF as one of the others, but 3 or 4 other markers that are, and he has the telomerase promoter as an additional marker now. And again, he can sort out the tumors that have these mutations, and those are more likely to be cancers. So those 2 approaches are used. And we still have problems with NIFP in sorting that out. But if there's a RAS mutation, it's more likely to be that. Yes. Is that answer?
I guess NIFP is impossible to diagnose by FNA.
Right. Yeah.
So presumably we would have to diagnose it by frozen section. So are you suggesting that we freeze entire nodules?
No, and that's a good question in terms of the practical aspects of this. So if you have a nodule, the practical thing to do at frozen, which has to be a quick examination of the tissue, is just to look at 1 or 2 sections. And if one doesn't see invasion, then it might be a NIFP in the differential diagnosis, but you can't really exclude the possibility that there's invasion elsewhere. So it's handled more like a follicular adenoma, follicular carcinoma differential is at that time. Yes.
So when the cases of follicular variant of microcarcinoma were reviewed to come up with the NIFP diagnosis, what was the outcome? What was the status of the other lobe if some of these cases had total thyroidectomy? Mm-hmm. Was there any other NIFP on the other side, or was that a criterion that the other side should be negative?
Yeah, the other side could be negative. They could have benign adenomatous nodules or other things, but not another lesion that looked like this. Because if there were more than one NIFP in a thyroid, it was excluded from that series of 102 that was published in the series. Okay, so this is this last slide summary. So we'll transition a little bit for another 10 minutes or so and talk about epithelial mesenchymal transformation in thyroid cancers. We've been studying this now for the last 7 years or so. And here's another thyroid cancer. This is an autopsy specimen, so the patient has died. And here's the big cancer in this lobe. There may even be a little bit of cancer over here on this side, and this, of course, would be the trachea. So it looks like a fairly aggressive tumor, and in this case, most likely the patient died because of this cancer. And this would be anaplastic thyroid carcinoma, if you see this on cytology or in tissue sections as this, where you have really very pleomorphic cells, lots of mitoses and other features that would help to make the diagnosis of malignancy. And there have been several theories about the development of anaplastic thyroid carcinomas. Remember we said these are very aggressive. Patients usually die within a year after the diagnosis is made, regardless of the types of treatment. There are some recent papers in the literature, one from Mayo, that if they use anaplastic cancers that had not metastasized outside of the neck and treated those patients very aggressively, they did better. They went on to survive for 2 or 2.5 years. But in general, patients usually succumb to these cancers. So Dr. Takano looked at these tumors and thought that through his studies that these probably arose from stem cells within the thyroid. We don't really know the normal stem cell in the thyroid as such. We're still looking for that with some of the markers that are used to study cancer stem-like cells. But he proposed that these tumors came directly from a stem cell, and even went on further to suggest that other types of thyroid tumors, the well-differentiated tumors, arose also from cells that were maybe just partially differentiated but stem-like and went on to these tumors. So part of this hypothesis is probably correct. But another part is not as a pathologist, because when surgical pathologists are looking at thyroid with anaplastic cancers, about half of the cases would have a papillary carcinoma associated with these as the most common type. Sometimes it's follicular. So one knows that there's probably a de-differentiation of papillary carcinomas to anaplastic thyroid carcinomas by that spatial relationship between the two types. So this is maybe partly true that there's stem cells, and it's been shown that there are stem cells in the thyroid. We showed this earlier to show that there's this progression, increasing number of mutations. So one finds, say, TP53 beta-catenin mutations in the anaplastic, as well as about a third of these have BRAF mutations, whereas papillary thyroid carcinomas would have BRAF commonly in these others, but usually not P53, TP53 or other mutation. So that's another line of evidence that we're dealing with this de-differentiation towards the tumor. A few terms that we'll use in this brief discussion would be just stem cells, these cells with unlimited self-renewal or multipotential ability, and then they're related to progenitor cells, and such transit amplifying cells are sort of activated stem cells, and then the cancer stem cell or cancer stem-like cell. One uses a like concept to lots of skeptics when these grants are renewed at the NIH in terms of cancer stem cells. So about the denial of the or questioning the existence of these cells. And it's a very controversial field, as many of you know. So ideally, this is what one would like to do. One has a thyroid. Somewhere in the thyroid, we have regular stem cells that would give rise to all the other cells in the thyroid. We have progenitor cells and transit amplifying cells that are usually activated by presumably a series of mutations. With the Takano model, these cells were there before, but one has these cells mutated to become cancer stem cells. And this is only a small percentage of the cells within the tumor, usually less than 5% and 1 or 2% in general. And one has a tumor with the stem cells in black here. If one uses conventional therapy, whether it's the anaplastic thyroid carcinoma or a glioblastoma multiforme, high-grade cancer of the brain, one can usually eliminate many of the cells by surgery and chemoradiation therapy. But you have resistant cancer stem cells. They're usually chemotherapy resistant, so the tumor recurs or the patient relapses. And the ideal or the goal would be to have the cancer and the cancer stem cells develop specific therapy once we learn more about the biology of these cancer stem cells, and then eliminate those cells with this specific new knowledge that we'll hopefully gain, and then eliminate the entire tumor, and then have one way of controlling these tumors. One of the things that many investigators that observe over the years is that epithelial mesenchymal transition that's going from epithelial-like cells with a lot of morphologic features as well as biochemical features are seen in thyroid as well as liver, pancreas, and many organs of the body as tumors develop. In this case, a few years ago, one of our residents made a tissue microarray and had like 160 or so cases in there, and did stains for some of the markers of epithelial mesenchymal transition, or EMT. And here, ecadherin is seen in the papillary carcinoma and in the inset, showing that it's membranous staining. But in the anaplastic, it was a lot less of EMT that was present within these cells. A few of these, as the next chart shows that there is some overlap between the two, but this is usually in the well-differentiated or normal thyroid. Other markers of this mesenchymal transition, slug, SNA1-2, TWIS1, are some of the markers that are seen in anaplastic and not in the papillary or other tumors. The intermediate aggressive groups, they're sort of overlapping with the hobnail variant having some of these features as such. But here you can see that dramatic difference between the two. The little circular areas, I think my pointer died, the little nests of cells are papillary carcinomas that you can recognize by the cytologic features within an anaplastic carcinoma. So we have de-differentiation here. And you can see that the slug is not expressed in any of those nuclei. whereas in anaplastic cancer, most of the nuclei are expressing slug. So again, this sort of supports the idea that there's this trend, de-differentiation as such, and that slug is present within those other cells. So we wanted to use an experimental model to look at this, and used cell lines. There are multiple cell lines available, and TGF was really a good model to look at transition of these. So you use a small amount of TGF beta and look at cells for a few weeks, and you can see in red the presence of TGF beta inhibitory at these concentrations in these cells compared to the control cells that were not treated with TGF beta. We did this all in serum-free media so as not to get things confused with all the ingredients, ill-defined ingredients in serum as such. And so the markers, such as cytokeratin, was decreased in the presence of TGF beta. You can even appreciate the cells look a little larger. Other markers, such as vimentin, would be increased in the presence of TGF beta, both at the immunofluorescent level or by doing RT-PCR, very crowded slide. But you can see E-cadherin goes way down, vimentin goes up as a slug, snail, and some of the other markers of EMT. So this supported, at least in our 2 cell lines that we were using here, that one had EMT developing in the thyroid tissue. And at the protein level, similar type finding, which could be quantified in this case, showing again that one has increase of slug as one marker of EMT. Then we took the cells and put those into immunodeficient mice. We had groups of just with serum, some with serum-free, and then with TGF beta. And even though this took about 2 months or so to get the tumors to the sites where the animals were sacrificed, and you can see that in the, even without TGF beta stimulating anymore after those 21 or 28 days in culture, the tumors continued to grow, and one really has increased expression of TGF beta compared to the controls here, and by looking at tumor weight, tumor volume. So indeed, this is occurring. One can see that some of these genes that are present, not only in EMT, but also with stem cell type markers, SOX2, TWIS1, one has increased expression of these in the tumors from the TGF beta treated animals. And then if you look at the histology of the tumors, above here, there's one cell line, TPC1. You can see that the cells are infiltrative, looking more aggressively. In another cell line, there's even one in a blood vessel. And then we document again that one has increase in the expression of the markers. So there's definitely ongoing, even though TGF beta was the initial trigger for the model, this goes on for months in the in vivo aspects of the experiments. And if you look at some features of stem-like cells, cancer stem-like cells, and thyrosphere or sphere formation is one of these that's used commonly by people that work in this area, measuring the serum-free versus the TGF beta and counting the spheres, and these spheres are aggregates of cells, again in serum-free media. One has increased expression of this. So not only does one have EMT going on, but increase in cancer stem-like cells with these cell lines. Again, suggesting that there's this relationship between EMT and cancer stem-like cells. That's been shown previously by groups in looking at breast cancer. And then trying to isolate this small population of cells that are forming spheres. One sees the aldofluor negative and aldofluor positive cells that form spheres in the serum-free media and absent within the negative. We've gone on to be able to show that one can indeed generate cell lines of these aldofluor positive clones as such, and they're being very useful for a lot of studies. Here we're just showing that one has markers such as NANOG and SOX2 OCT4, cancer stem cell-like markers. As one gets more passages with these tumors, there's increased expression of these stem cell-like markers with passage. But the story, of course, so we're looking at trying to figure out the biology of what's going on here, trying to understand more about stem cells in anaplastic thyroid cancer. And the story, of course, is a lot more complicated than just the presence of these cells. Because as pathologists, if one looks at cells in the, say, breast cancer, they're nice round cells, epithelial shape. You don't rarely see mesenchymal cells unless you're dealing with a metaplastic cancer or some other form. They're usually epithelial in the metastatic focus as well. And so the question is, what is that? What's going on in terms of seeing epithelial and also epithelial in the metastatic focus? And several individuals have postulated, of course, that there's, in addition to epithelial to mesenchymal transition, there is mesenchymal to epithelial transition that goes on. So one has the epithelial cells, one has the mesenchymal transformation, these metastasize to the liver or lung or other sites, and then there's a reversion with MET and some of the markers like TWIS and PRX1, a new marker for EMT. These usually change in terms of the amount. And these are some of the things that are driving the cells back towards an epithelial configuration in the metastasis. So it's a plausible explanation for this widely observed lack of mesenchymal cells if this EMT hypothesis is really going to be held up with most cancers. And so there's a lot more work being done with this, and certainly in terms of finding ways of targeting cells, whether it's in the MET phase or in the epithelial phase, to try to get rid of these cells, cancer cells, as well as the cancer stem cells. And so to summarize this as the final slide here, one has epithelial cells. We've looked at EMT with the TGF-beta model, and then one has mesenchymal cells that results for this in some thyroid cell lines. There's this increased relationship between cancer stem cells and mesenchymal cells. And with the cancer stem cells, what we're studying now is looking at exosomes as one of the real markers of aggressive tumors, that they interact with all of these different areas, immune cells, extracellular matrix, the CAF, and promote angiogenesis, leading to colonization and metastasis. So we've sort of shown you a little bit of data for the top part of this, and everything else here is sort of ongoing. And a lot of work is being done with liquid biopsies, as you know, in looking at cancer stem cells or other cells that one can use for diagnosing patients without really going after the tissue by repeat biopsies. So in summary, EMT present in dedifferentiation in terms of thyroid. And then we have the TGF-beta model that's been used with other systems as well. EMT is associated with increases in cancer stem cells in some tissues. It's been shown in breast as well as in thyroid. And yeah, I think that's the last of our slide. I'll be glad to answer any questions or comments. Yes.
Could you expand a little bit on your understanding in your model of mesenchymal to epithelial transformation? And one of the reasons I'm asking this is that I have an interest in renal pathology, and we know that in kidney disease, the amount of interstitial fibrosis correlates with renal function. And the hope is that we can, and that is due to epithelial mesenchymal transformation, and the hope is that we can reverse this by using some kind of a mesenchymal to epithelial transformation model. Yeah. So can you expand how you do the mesenchymal to epithelial transformation in your model?
Yeah, we haven't done too much as yet, but in terms of the literature, what's done, and we've measured some of these things in the cells, but we haven't really done the in vitro experiments. But the thinking is that TWIS usually goes up doing this EMT, and so one has decreased levels of TWIS, presumably slug, although it hasn't been shown for slug, PRX1, which is another marker. And so one of these factors would be the decreasing level. I think another important factor that's not here are microRNAs. There are microRNAs that are really important for regulating EMT as well as MET. MER 200 family, I think, would be one group. So I think one has to probably play around, if you're trying to do the model in vitro, play around with some microRNAs that are going on, working in the cells, as well as some of these other well-defined factors to really shift things back to EMT. Yes?
What's the status of various markers, EMP markers, in the indolent tumor?
Oh, in terms of, yeah, that's and thing that we wonder about sometimes. So indolent tumors, which endocrine tumors are great examples of indolent tumor. Most are usually pretty low grade and so forth. And certainly, in terms of benign tumors, even pituitary, low-grade thyroid cancers, they have stem cell markers as well, but the levels are a lot lower than anaplastic cancers. So the levels would be one thing that's probably different between indolent and more aggressive tumors. And again, I think mutations, the genetic here is probably as important, or maybe more so, than some of these others with EMT. Okay.
So what's your recommended handle, like if there's two lesions, like a NIFP?
Oh, if you have two lesions that are NIFP, and I think the critical thing would be like the microcarcinomas. If the tumor is non-invasive, that's the most important thing.
Yes.
So if you have two or even three non-invasive, those are probably going to be fairly indolent. We don't have the data to support that, but it's sort of a feeling that because they're encapsulated or circumscribed, they're not going to be going to lymph nodes or to other sites as metastatic foci.
So probably you sign that as a comment, so it looks like a NIFP, but it's multiple, does not meet the diagnostic criteria.
Correct, yeah, just like that. And a comment, of course, that's helpful, and maybe even giving the clinician a call, letting them know what you're thinking, in addition to the comment.
What do you think about a resected tumor, like a papillary? Do you think it's good to do molecular testing to stratify for patients for further treatment, like a total mutations?
In some cases, it depends on the budget and so forth. In the hospital, we're always strapped with that. But if we have cases, of course, that looks like a conventional papillary, and but it's in a lot of nodes, and it has, the margins are positive. I think in that setting, it's probably very important to look for telomerase promoter, BRAF, and other things, for sure. Yes?
So some cases of, for example, benign conditions like Hashimoto thyroiditis can be associated with quite a bit of nuclear polymorphism. Most of that comes from Hurtle cell proliferation. There is also, in some cases, you can see extension beyond the thyroid into the parathyroid soft tissue of both inflammatory infiltrate, but also some of the follicles, thyroid follicles. So what is your approach in differentiating those cases, occasional cases of otherwise benign Hashimoto thyroiditis cases that are exuberant from cancer?
Yeah. Certainly looking for mutations would be one thing. Even though Hashimoto's is thought, at least a few cases, one or two cases in the literature, have the red PTC translocation, I think most cases do not. And so if one looks for a series of mutations there and don't see, I think morphology is usually the best way to sort that out, even if it's just, lymphocyte infiltration. And remember, in terms of pleomorphism in endocrine tumors, we usually refer to this pleomorphism there as endocrine atypia. And those are usually benign things, or at least they're not usually malignant. It's often reassuring with an endocrine tumor to have this pleomorphism as such. Adrenal cortical tumors would be a great example of that. Nice round nuclei, you worry about that a lot more than pleomorphic nuclei in an adrenal cortical lesion and other endocrine tumors. But I think molecular would be one answer, but may not be necessary in most cases. Yes?
Are you aware of any role of oxygen or hypoxia in the epithelial to mesenchymal transition?
Certainly in stem cells, it's important. Presumably, I think there's data for cancer stem cells that hypoxia does make a difference in terms of driving. As a matter of fact, the suggestion in the literature and talking to some of the people that work with a lot of stem cells is that if you can't get your cells to grow that well, your cancer stem cells to grow or a normal stem cell, then lower the oxygen tension, and that usually helps. And as we know, a lot of pathways are turned on, right, by hypoxic condition, such as in pheochromocytomas and these other tumors. Okay. No other questions? Thank you very much for your time.